Welcome. I'm Dr. Raed Dweik, Director of the Pulmonary Vascular Program in the Department of Pulmonary Allergy and Critical Care Medicine at the Cleveland Clinic. I'm pleased to welcome you to the Cleveland Clinic's Respiratory Virtual Grand Rounds. These are case-based presentations where I invite some of the leading authorities in the field of respiratory medicine to discuss an important topic that I believe is worthwhile to your practice in order to help you be more confident in approaching and managing patients with a certain disease. For today's presentation, I have asked Dr. Joseph Parmabil to provide you with an overview of the pulmonary arteriovenous malformations with a focus on hereditary hemorrhagic telangiectasia, or HHT for short. Dr. Parmabil is the director of our Hereditary Hemorrhagic Telangiectasia Center of Excellence at the Cleveland Clinic. He earned his Doctor of Medicine degree from Pécs University School of Medicine in Pécs, Hungary. He completed his residency at Henry Ford Hospital in Detroit, Michigan, and his fellowship in pulmonary and critical care medicine at the Mayo Clinic in Rochester, Minnesota. Dr. Parmabil is a member of the American College of Chest Physicians, the American Thoracic Society, and the Pulmonary Hypertension Association. Dr. Parmabil's case-based presentation includes integrated audience response questions that are designed to help you test your knowledge as you follow along. Here's Dr. Parmabil.
My name is Joe Parmabil from the Respiratory Institute at Cleveland Clinic, and during today's presentation we're going to go and talk about our approach to diagnosing and managing pulmonary AV malformations with a specific focus on the most common cause that leads to pulmonary AVMs, which is a genetic disease called HHT, or hereditary hemorrhagic telangiectasia, also known as Osler-Weber-Rondeau syndrome. All right. So today's objectives are basically to understand the clinical features that contribute to the diagnosis of HHT, because usually that's what you'd be looking for when you see a patient with a pulmonary AVM. And the other important thing is to appreciate that AVMs, especially in the lungs in HHT, are often quite silent, which can have devastating consequences. And so screening for these in a patient with a known diagnosis of HHT becomes an integral component of disease management. And finally, we'd talk about how to recognize the approach to diagnosing what an AVM is and how to manage once you do identify these AVMs. So what is HHT, or hereditary hemorrhagic telangiectasia? It is a genetic disorder. It's got autosomal dominant form of inheritance, but it's got variable penetrance. And what I mean by variable penetrance is that even though it's autosomally dominant inherited pattern, the disease can come on later on in life, and even within the same family, the disease manifestations can be quite varied. Usually the disease is characterized by two cardinal manifestations. It is an angiodysplasia, meaning that it's a disease that affects blood vessel integrity, and it makes them quite have fragile blood vessels. And the two cardinal involvements are patients respond by forming either telangiectasias or larger AV malformations. And hence you tend to see recurrent epistaxis because of the telangiectasias in the nose. They can get smaller telangiectasias on the skin and the mucosal surfaces, especially the mouth and the lips, etc. And obviously, internal organ manifestations tends to be with the larger ones, especially AV malformations. Mainly the two or three organs we worry about are the lungs, the brain, and maybe to a certain extent the liver as well. Now, the key thing to remember with this disease is that most of these patients live well into their 80s or so if they're appropriately managed and taken care of, but the disease severity is primarily related to lung involvement, and that's why HHT is primarily taken care of by lung physicians, because when they have lung involvement, it can shorten life expectancy by an average of 7 to 10 years unless adequate screening and therapy is done. Now, the important thing is, even though it's a genetic disease, HHT is a clinical diagnosis. And as you can see at the top of the slide, it talks about the so-called Kurosawa criteria. We have 4 criteria. And as you see at the bottom, you have definite HHT. We've got 3 or more of these criteria, possible if it's 2, and unlikely if less than 2 criteria are there. And the 4 criteria are epistaxis, which is spontaneous recurrent nosebleeds, telangiectasias, which tend to be multiple. And I think the key word you're going to hear throughout the slide is multiplicity or multiple lesions. And a typical site such as the lips, the oral cavity, the finger, the nose, basically areas that are prone to recurrent injury, such as skin-related changes on the hands or the face and the mouth, etc. Internal organ involvement in the GI tract can be seen usually with telangiectasias. With the liver, the lungs, the brain, and the spine are usually larger lesions such as AVMs. And finally, the family history when you have a first-degree relative with the disease. Now, the next slide shows you the spread of internal organ manifestations from this disease. Like I said, the most common tends to be the nose with epistaxis, and close to 95% of these patients, by the time they hit age 40, tend to have this involvement. Mucocutaneous, such as the skin of the face, the hands, and obviously the lips, the mouth. Conjunctival involvement is not that uncommon, and it can be seen. Occasionally patients can have bleeding from that. The GI tract, again, 30%. Now the lungs, among the internal organs, the lungs tend to be the most common at 27%, or 27 to 30%, and the brain and the spinal cord is less, and then the liver is the least. Now, the important thing to remember, and I'll say this briefly about the liver, is that even though it's 12%, what we got to remember is this 12% is based on symptomatic liver involvement. Most patients, up to 70-80%, can have asymptomatic liver lesions that are there but just don't do anything. All right, so a little bit about the genetics. Like I said, it's autosomal dominant. It's got variable penetrance, meaning that it comes on later on in life. So as a patient ages, the disease can manifest. And the other thing is that there's significant variation even within the expression of the disease within the family. So in other words, the dad may have just mild nosebleeds, but the child can have significant nosebleeds. The dad may have lung AVMs, and the child may not have lung AVMs. So there's more to just the genetics and other epigenetic factors that we still do not know of yet that do play a role in the expression of the disease manifestation. Because it's autosomal dominant, the probability that an HHT-affected parent has a child with the disease is around 50%, and like I mentioned, it is progressive with age, and by the time most patients are usually 40 to 50 years of age, they will have symptoms. And this is important, that this progressive nature with age, because sometimes you may not have nosebleeds or the skin manifestations, and you may have just internal manifestations as a child, and that's where genetic testing comes into play, where if the father has a mutation, for example, we can check the child for the mutation even before the disease is present, so it allows us to screen in an effective and cost-effective manner as well. So thus far, we've identified 3 genes for this disease. There are 2 other chromosomal locations wherein there may be an abnormality, but the genes at that location are yet to be identified. The 3 genes are the ENG or endoglin, the other one's the ACVR1 or activin receptor-like kinase, also known as ALK1, and then the last one is the SMAD4 gene. Now, with genetic testing, we can identify mutations in these 3 genes, and when you look at it collectively, up to 85% of cases are because of these 3 genes. 75% are because of the ENG and ACVR1 mutation, and the remaining 5 to 10% in those that are ENG and ALK1 negative are because of SMAD4. Now, just a few words about SMAD4. SMAD4 is unique because these patients, unlike the other HHT patients, are at risk of developing a combined syndrome. So the combined syndrome is they have features of HHT and they have juvenile polyposis syndrome, which predisposes them to preneoplastic polyps of the stomach and the colon, which, if not treated, can lead to gastric and colon cancer. So you have an additional screening paradigm and pathway for those SMAD4 patients. But on the right-hand side of the screen, you will see that the risk of lung AVMs tend to be higher with the ENG and the SMAD4 patients, but we've not used genetics as a benchmark to decide who needs to be screened. We've seen patients even with ALK1 mutation to get lung AVMs, even though the standard teaching is the ENGs tend to get lung AVMs and the ALK1s tend to get liver AVMs. We screen them all because we've seen ENGs to get liver and ALK1s to get lung as well. And the various type of mutations seen are deletion, duplication, splice site, and missense mutation. So what do these three members do? All three genes code for members of the TGFbeta superfamily. Now, TGFbeta has an important role, at least what we think of today, in allowing the vessels to remain structurally stable, and when vessels do get injured, they orchestrate smooth, timely, well-coordinated healing of the blood vessels so that they heal back in a stable, strong state. When you have mutations in that, these patients heal in an aberrant form because of dysregulated signaling through TGF-beta, and they get these fragile, tortuous blood vessels that either shunt through capillary beds or are fragile and bleed, and hence you get the disease manifestations of this disease. ALK1 codes for a type 1 membrane receptor. TGF-beta needs, when it binds to the cell membrane, it brings together a type 1 and a type 2 receptor that is then stabilized by endoglin, which is a type 3 receptor, and then the intracellular signaling molecules are a variety of SMADs, like SMADs 1 through 8, and the final pathway is they all finally localize onto SMAD4 that goes into the nucleus and facilitates transcription of various other factors that are involved in in proliferation, in apoptosis, in differentiation, fibrosis, etc. So we come to our first case. We have a 27-year-old woman who presented to us for evaluations at our HHT Center. She had exertional dyspnea for a period of almost 2 years. It occurred mainly when she was working out, but she had no associated symptoms of chest pain, cough, hemoptysis, wheezing, or orthopnea. She did give a history of spontaneous epistaxis 2 to 3 times a week, so not a lot. She did not have to go to ENT to get any laser or anything of the sort like that. And she stated that it's interesting that in her family history, there is HHT in her dad and in her dad's mother. She was discharged from the ER a week prior to coming to see us because she went to the ER for these transient neurological symptoms for almost 16 to 18 hours. She had symptoms of expressive aphasia. There was left-sided paresthesias and numbness along with significant photophobia. She went to the ER. The ER didn't feel that a significant neurological event like a stroke could be happening because of her age. And however, they did an MRI of the brain and said, well, there's nothing wrong here, and said, you likely have an atypical migraine headache, and was discharged. However, given our history of HHT, she was concerned and she came to see us. So when we saw her, her vital signs were pretty stable, except at rest her pulse ox was 95%. She had telangiectasias on her lips and fingers, and I'll show you her fingers in a little bit. And and her lung exam was completely clear. There were no vascular bruits, and even a cardiac exam, no murmurs. Her S1, S2 was completely normal. And when you look at the chest X-ray, you will see that there are these nodular lesions, one here, one down here, maybe another one here, another one here. That is definitely seen on her chest radiograph. So these are her fingers, and as you can see, she's got these telangiectasias here, 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 and like I had said, like the chest X-ray showed multiple lesions, here again multiple lesions, and whenever multiple lesions are noticed, HHT always should come up to the top of the differential diagnosis list. So because of that, we decided to pursue this with a CT scan of a chest, and lo and behold, as you can see from cuts going from the carina at the top all the way down to the base of the lungs, this is 1, 2, 3, 4, you can see multiple nodular lesions, one here with a feeding vessel, here with a tortuous vessel, another one here, and then here. I mean, there are multiple lesions throughout these scans, all consistent with AV malformations. So the question is, what is the likely cause of a symptoms of dyspnea, as well as could there be a tying cause over here for her transient neurological symptoms? The choices are, is it atypical migraine? Is it these pulmonary AVMs? Does she have a ventricular septal defect that could be causing this? Or is this all just asthma? And the answer is pulmonary AVMs. Now, migraine headaches are seen in patients with HHT, but to have these neurological symptoms of aphasia, numbness, etc., makes you extremely worried that she's having paradoxical emboli going through these AVMs right across into her heart and being showered into her brain, causing her neurological symptoms and not a migraine. And we've seen that in these patients who have pulmonary AVMs, and that is something that is very worrying. And we have seen young patients who have a permanent disability from a stroke because of untreated pulmonary AVMs. Now, a similar thing can happen with ventricular septal defects or any congenital defects in the heart. However, the cardiac exam would have been abnormal with a murmur heard. However, her cardiac exam was completely unremarkable. And asthma, we have seen asthma symptoms in HHT patients because TGFbeta does play a role in eosinophil apoptosis. However, her symptoms are unlikely to be related to asthma. All right, so what are pulmonary AV malformations? These are abnormal communications between the pulmonary arteries, usually the smaller precapillary arteriole and the postcapillary pulmonary venule or the vein. And the problem is it shunts away from the capillary bed, thereby leading to right to left shunting and causing hypoxemia. The other issue is that you can have paradoxical emboli, either of infected material or just clot thrombotic material, and it can lead to cerebral abscesses. Usually the cerebral abscesses in these patients, the infected material arise from the mouth, the oral flora, or they can even have a cerebral stroke. Now, 80% of AVMs, when diagnosed, occur in the context of this disease called HHT. And when it is in HHT, they predominate in the lower lobes. Close to 90% of them are in the lower lobes. They're often multiple. Like I said, the key word here is multiple for this talk. And they're bilateral and can cause hypoxemia and CNS consequences. Now, a brief word is that in patients with HHT, they can have CNS AV malformations. But when you look at HHT, the most common cause of CNS trouble or insult is because of silent pulmonary AVMs rather than because of a primary AVM in the brain. So how can we diagnose pulmonary AVMs? Only half the patients present with dyspnea and exertion, and the more multiple the lesions like this patient had, you're going to see more dyspnea, but the majority of patients don't present with any symptoms because they tolerate this pretty well. And if you just based on clinical symptoms, as the next point shows, you would miss a majority of AVMs. That's why screening is of critical importance in the management of these patients. And obviously, this patient was lucky in that she presented with a transient ischemic attack as part of a neurological complication and did not present with a devastating stroke as her presenting manifestation for her pulmonary AVMs. Other rarer respiratory symptoms include hemoptysis, because these are fragile, they can cough up blood. Sometimes they can have chest pain because of steal of blood away. From the chronic hypoxia, they can have clubbing and cyanosis, and obviously, rarely in a large pulmonary AVM, you can hear a vascular bruit across the lungs. Now, rarer complications are massive hemoptysis when you have rupture of an AVM into the bronchus, hemothorax if it ruptures into the pleural space, and CNS complications is what we worry about. It can be seen in 13 to 20% of patients, including brain abscesses, stroke, TIAs, and I put migraines here. It's technically not considered a devastating complication, but we have seen, similar to the patients who have congenital heart defects, a higher incidence of migraine headaches in these patients who have pulmonary AVMs. So since we said that screening is an integral way in which you identify patients, because most of them are not symptomatic, what is the best screening test that we may use to try and identify patients with HHT who may have pulmonary AVMs? And you could go with a multitude of ways. You can just go by symptoms, but we know that symptoms aren't the best. There's doing an ABG with an AA gradient, which is quite specific, but it is invasive. The chest X-ray and the nuclear scan, sometimes smaller AVMs can be missed on a chest X-ray. The nuclear scan is not good in identifying as a screening test, but it's a good test in specifying, yes, that's what it is. And today, the standard test that we use to screen for pulmonary AVMs is a contrast echo or a bubble 2D surface echocardiogram, and that seems to be an extremely sensitive study. And when you add an echo and a chest X-ray, the sensitivity goes up to close to 100%. And so that is usually the standard way in which we screen for the presence of or suspicion for a pulmonary AVM. And if this is positive, so the bubble study is positive for a pulmonary shunt, then the testing of choice to confirm that this is indeed a pulmonary AVM is to do a contrast-enhanced chest CT. Now, in the past, pulmonary angiography used to be done. No longer. The sensitivity of chest CT is much higher than angiography, and the CT shows small or thrombosed AVMs that could be missed by angiography. And as you can see over here again, you see these two AVMs here, another one here posteriorly. Now, angiography, like I said, is no longer used to diagnose, but it is used still as a modality to help treat these patients. And when we come to treatment, we'll talk a little bit more about the role of angiography here. Now, what are the other tests once you have identified that, well, the patient has a bubble echo that may be positive? Can we identify how severe the shunt is, quantify the shunt? And 3 studies have been used. The contrast echo, a shunt study, again using ABG method, or the radionuclide lung scan, and we'll talk briefly about each of them. So the contrast echo is the method of choice today to assess for the presence of right to left shunt as a screening test. 4 to 5 ml of agitated saline is injected with some room air into a peripheral vein, and the atria are imaged by 2D echo. And it's important to let your echocardiography colleagues know that you're worried about an intrapulmonary shunt, because then they can time it based on your ECG cycles, because in the presence of an intrapulmonary shunt, there is a delay in the appearance of the bubbles in the left atrium, because they appear 4 to 8 cardiac cycles later, as opposed to this being related to a PFO or an atrial septal defect, wherein they come in quite quickly. And that does help, and alerting them to this makes them be vigilant to try and time this along with the cardiac cycle. Now, what are the pitfalls of contrast echo? It's extremely sensitive, because we have seen many patients who have a bubble echo study that's positive, and then you go ahead and do the CT scan, and the CT scan shows no AVMs. And the other thing is, once you have identified an AVM and you treat it, even though you may have coiled it off, they still have microscopic feeder vessels, and the bubble echo, if repeated after that, can still be positive. So what does a positive study mean? Is this a false positive study? And in the past, people thought it could be, but right now we're starting to realize that these may actually be positive, because there was a paper that came out of Canada that showed a patient who had a microscopic AVM meaning the bubble echo was positive but the CT was negative, and the patient died for an unrelated reason, and when they did an autopsy of the lungs, they did see microscopic AVMs. So we feel that this is useful to say that the patient likely has microscopic AVMs, but the issue with contrast echo is it doesn't tell you how severe the shunt is or how many AVMs the patient has. And because of this whole concept that you can have microscopic AVMs, and now we're becoming more vigilant about how many CT scans does a patient need, especially these young patients over their lifetime, there's been a grading system to see who is a patient we need to send for a CT scan. So when a few bubbles are seen with minimal left ventricular micro bubbles seen, we tend to just watch these patients rather than subject them to CT scans. When there are more bubbles, such as moderate left ventricular micro bubbles seen, and in the higher ones, stage 3 and 4, we tend to say, okay, let's do a CT scan of the chest because the likelihood of finding a larger AVM is high. And the other reason why this is useful is on serial studies, it does help us. Let's say a patient sees us and they have a grade 1 echo, but they come and see us 3-5 years later, and now their grade has gone up to a 2 or 3. It tells us, well, this is highly suspicious for new AVM or a large AVM or an existing AVM to grow, and a CT scan would be indicated. On the shunt study with the ABG method, I don't think we do it here in the United States, but I know in Canada they still do it, and it is used to give us a quantification of the shunt fraction. And you measure the arterial oxygen on room air and after breathing 100% O2 for 15 minutes. And if there is an increased AA gradient, more than 5%, it indicates hypoxemia related to right to left shunting. It's quite specific, but this is primarily used in a way to follow patients along. And what I mean by that is if at the first visit your patient has a shunt fraction of, say, 18% or so, and then you send the patient for therapy, and then the patient returns to come back and see you in a year or two, and if the patient says that they are still short of breath, rather than repeating a CT scan or something, you could do the study, and if you see that the shunt fraction is now 4%, it's highly unlikely to be because of a right to left shunt, and looking for other causes would be helpful. So that's the whole reason why people do this, is they can do it post-procedure to document, yes, the shunt fraction is reduced, and then on follow-up, does this shunt fraction go up or not? Same thing done, which we do here in the U.S. more, is with the nuclear lung scanning. Basically, this study involves a technetium-labeled albumin, macroaggregated albumin particles that are injected, and based on its size, majority of these should be cleared by the lungs. Less than 5% should leave the pulmonary circulation and enter the systemic circulation. However, in the presence of pulmonary AVMs, these do leave, and if more than 5% is found either by screening over the brain or the kidney, then you know that the patient does have a quantifiable shunt. And the same principles apply to this as has been done with the ABG method. It's more as a follow-up to see that indeed the therapy has worked. So question 2, we've spoken about assessing response to therapy, but what is the mainstay of treatment for pulmonary AVMs when it's identified? Number 1, surgical resection of the AV malformations. Number 2, lung transplantation. 3, coil embolotherapy, or 4, anticoagulation with warfarin. And the answer is 3, coil embolotherapy. Surgical resection used to be done in the 60s and 70s before the development of interventional radiological methods of coiling this. Sometimes large AVMs, especially when they may have burst into the pleural space causing hemothorax, can still be warranted with surgical resection. Lung transplantation is rare nowadays for this. It is usually done in patients who have diffuse AVMs that cannot be coiled, or there are too many to be coiled and still the patient is quite significantly hypoxemic. Anticoagulation with warfarin, we tend not to anticoagulate these patients because that tends to be the therapy that's been performed for patients who have paradoxical emboli in the setting of either a atrial septal defect, a PFO, etc. But in these patients, when they already have fragile blood vessels with epistaxis, GI bleeding, putting them on anticoagulation can only make things worse. So the treatment of pulmonary AVMs and HHT are primarily to prevent these severe complications, particularly brain abscesses, brain infarction, and hence treatment is warranted even in asymptomatic patients. Granted, in our case, our patient was symptomatic and warranted treatment, but if you found an asymptomatic AVM, it does warrant treatment in those patients as well to prevent subsequent consequences. Transcatheter embolotherapy of AVMs using detachable steel coils. Nowadays, they sometimes use these amplats or plugs are the mainstay of treatment, as can be seen here. You have an artery, here's the bilobed vascular malformation in the vein, here's the catheter coming in, the coil is deployed, and now when you shoot the dye, you don't see the malformation anymore. So if an AVM is identified by screening in an asymptomatic patient, because we said asymptomatic patients do benefit from treatment, which ones should be treated? So should all AVMs be coiled? That's the first question. Second question is, AVMs with a feeding vessel more than or equal to 3 millimeters in diameter should be treated. Only patients with multiple AVMs should be treated, or only patients with AVMs in the lower lobes should be treated. And the answer is any AVM with a feeding vessel more than or equal to 3 millimeters in diameter should be treated, because clearly the risk of stroke or untoward brain consequences has been primarily seen in patients who have a feeding vessel more than equal to 3 millimeters in diameter, and your thoracic radiologist should be able to easily assess for this. So the risk of cerebral complications is related to the size of the feeding vessel of the AVM, and more than equal to 3 millimeters in diameter is an indication of embolotherapy. However, smaller AVMs with a feeding vessel of 1.5 to 2 millimeters is also justified sometimes if it's technically feasible, or if the patient has symptoms from it. So what's the success of treatment for this? And overall long-term success up to 21 years is quite good, up to 75% success rate in keeping these down. However, we have seen these AVMs can reperfuse, so they can recanalize, and up to a quarter of these can recanalize. So in other words, follow-up is needed. And the recanalization either occurs from growth of non-occluded vessels that go to it, or from reperfusion or recanalization of these occluded AVMs. And as you can see on the scan here, the patient has AVM on the initial visit. After coiling, 10 months later, it still remains down. Now, and on the flip side, here's another long-term result, a patient that was seen in 2006. You can see the AVM here with the arrows, coiled off, comes back in 2011, screening visit 5 years later, and still remains coiled off. So patients with pulmonary AVMs should be proposed long-term follow-up regardless of the type of treatment. What's the best way to follow up? Chest CT is currently the best investigation, but I had mentioned earlier, in some of these patients, you could get a nuclear scan post-procedure, and if the percentage shunt fraction is low, you can repeat a shunt study to see if it still indeed remains low. If it's high, they will need a CT chest to confirm that it is because of growth or recanalization of the AVMs. And usually chest CTs are performed 6 months to 12 months after vaso-occlusion. And this is from an older paper, but being repeated annually thereafter. Right now, we've spaced out our screening protocols to once every 3 to 5 years because of the greater awareness of radiation dose for these patients. And slowly, MRI is coming up, but it's not yet prime time for MRI screening of the chest. Now, as I mentioned earlier, surgical treatment of pulmonary AVMs is rarely done. it's resection of lung lobes or segments with complex or multiple AVMs not amenable to embolotherapy, which is rare nowadays. But of course, if patients have AVM that ruptured into the pleural space or the hemothorax, in those patients we do surgery. And lung transplantation is rare now. It's mainly for patients with severe diffuse AVMs. So screening is warranted in any adult patient with HHT, even in children. We do it irrespective of their genetic status. However, if they're ENG, SMAD4, or family history, we say you clearly need it. Indication for AV screening in asymptomatic first-degree family relatives or children are debated, but we tend to screen them. And right now, the more cost-effective manner in children is because of the delay in manifestation is if the parent has an identifiable mutation, you try and identify the mutation in the child first. If the child does not have the mutation, then the likelihood the child has a disease is extremely low, and we don't even screen the child. But if the child has the mutation, then we screen those children. And if somebody's got a negative screening test, we still do not know what the optimal screening interval, at least for lung AVM screening is. So here's a screening algorithm that we use, a chest radiograph and a contrast. If it's negative, the likelihood of being absence of pulmonary AVM is pretty high. If it's positive, we do the chest CT, and if you see a feeding vessel more than 2 to 3 millimeters, then they undergo coil embolotherapy. If it's negative, the likelihood of macroscopic AVMs is low. And you see the comment over there, the prophylactic antibiotics, and I'll mention that in a following slide soon. Now, just a word on AVMs and pregnancy, because this is something important, as many of these patients are pretty young. And we know that the AVMs in the lung and even in the nose and other parts of the body tend to be hormone sensitive. So in other words, AVMs often increase in size and number during pregnancy, and these AVMs can deteriorate, meaning they can bleed or cause worsening hypoxemia during the second and third trimesters due to hormonal and hemodynamic factors. That's why patients with known pulmonary AVM should be offered close follow-up throughout pregnancy with high-risk OB. And these patients are best served by following at an HHT center, so that way should issues happen, they know what to do. Pregnant women who present with symptomatic AVM should be managed at these centers, as I just mentioned. And embolotherapy has been performed and effectively and safely even after 16 weeks of gestational age. So it can be done, but however, if we see a pregnant woman and we do identify smaller AVMs, we try, if technically feasible, to coil them off, so that way during pregnancy there is no growth. So there is always a conversation between us and the patient so that the pregnancy is planned properly, so that way no issues arise during pregnancy. And finally, you saw the recommendation about antibiotics. Anybody with a pulmonary AVM, because of the risk of infected emboli that can bypass the lungs and cause a cerebral abscess, all of our patients who have a positive bubble study or who have pulmonary AVMs, we give them prophylactic antibiotics 30 to 60 minutes prior to dental procedures. And this is because when you study the infectious burden of the cerebral abscesses that occur in these patients, they're primarily of oral source, and it's felt that during the cleaning you can have transient bacteremia, and usually that's cleared by the lungs, but in these patients, because of the bypass, that can escape it. And for the same reason, to avoid air emboli, we do not support scuba diving in these patients. And in the past, we used to use IV air filters for these patients, but now, with better and more vigilant nursing techniques, we just ask patients and healthcare centers to be more vigilant and careful in avoiding any air bubbles in inserted IV lines in these patients. So, like I had said, there is a greater awareness for this disease, and currently there are 15 HHT centers throughout the U.S. This is us over here, and one of the first centers was here at Yale. And if you do have a patient with HHT, sending them to one of these 15 centers would help, because it It is a multi-organ disease, and it tends to affect family members. And when you have multiple disciplines involved taking care of these patients, it gives better success and outcomes for these patients. So thank you for your attention, and I hope you guys tune in for more similar presentations. Thanks.
Thank you very much, Joe. In this case-based presentation, Dr. Parmabil discussed pulmonary arteriovenous malformations with a focus on hereditary hemorrhagic telangiectasia, the most common cause of these malformations. While HHT is a genetic disease, the diagnosis remains clinical with well-defined criteria, including epistaxis, telangiectasia, visceral lesions, and family history. HHT can involve several organs, including the lungs, the liver, and the brain, and can be complicated by hypoxemia and neurologic manifestations. The best screening test remains contrast echocardiography combined with a chest X-ray. This combination is highly sensitive but needs to be confirmed with chest CT scan with contrast, which is more specific. Pulmonary angiography is currently reserved mainly for therapeutic interventions with coil embolotherapy. Surgical treatment is rarely required. Dr. Parmabil also discussed the role of other treatments, including prophylactic antibiotics before dental and surgical procedures, and the importance of avoiding scuba diving. I hope that you found Dr. Parmabil's presentation on the hereditary hemorrhagic telangiectasia to be a useful update on this topic, and that it would help you with the day-to-day management of patients with pulmonary as well as extrapulmonary manifestations of this disease. Finally, on behalf of myself, Dr. Parmabil, and the Cleveland Clinic, I would like to thank you for listening to this Respiratory Virtual Grand Rounds presentation.